The conventional reasoning that has been in place for decades, if not, a century at least, may have been missing sort of part of the boat. The brain has been a very widely studied organ. There are so many unknowns in the realm of concussion. It's still an entity that gets stigmatized and gets criticized whenever somebody sustains a perceived concussion that, the rest and, be in a dark room and time itself. But when people come out of that and they go back to activity, whether it's just strenuous exercise or contact activity, and they get re-injured or re-flared up, and then they get into this realm of, post-concussive syndrome or chronic concussive syndromes, not much is done in the sense of further evaluating like what else could be the ground cause of the symptoms that they're having. So it's just, we've already figured out that you have a concussion or a chronic post-concussive syndrome, and all the symptoms that you're exemplifying on a daily basis, we have remedies to subdue those symptoms, but not really figure out if there's a core tissue that we can address or core tissues that we can address, if we can see that they're damaged or see that they're somehow glitching, to be able to put you on a path of actual recovery as opposed to palliation, if you will. In my world and in my own personal experience, ties back to is ligament injury in the upper neck. And so the upper neck protects and encompasses and houses the brainstem, or at least the lower part of the brainstem, where the vagus is one of the structures that branches off of that part of the brainstem. And so when you have excessive movement and mechanical forces or mechanical motion that nudges up against that part of the brainstem repeatedly, but on a small micro scale, you have a repeated stimulation of those neurological structures, or a reduction in stimulation of certain neurological structures where you start getting glitching. So simple example is somebody who has this type of upper cervical ligament damage and resultant hypermobility of those spinal segments, which then nudge up against the brainstem, could at random times have double vision, blurry vision, tinnitus or ringing in their ears, temperature control issues where they feel like their head is flush, heart palpitations, digestive issues such as constipation and diarrhea. They could have acid reflux for no apparent reason, balance and coordination issues, memory issues, anger issues, multitasking issues, concentration issues. So you have all these potential symptoms of potential systems in the body that could be misfiring or malfunctioning at any given time, and not all at the same time. Like POTS is a common diagnosis, postural orthostatic tachycardia syndrome. So when a person changes posture, so from lying to sitting or sitting to standing, their heart races. And so they get the label of POTS, and everybody thinks that the job is done, but that's just explaining what symptoms they have. It's not even trying to figure out what's causing the stimulation of the nervous system to make the heart race when you change it in position. Is it just a change in blood pressure, which is natural when you change position? Because more blood has to be shunted when you're upright versus lying down. Or is it actually something stimulating the vagus nerve, telling it to inappropriately raise the blood pressure more than it should when you because when you change position, you also change the position of your head and neck, and that doesn't get really paid attention to. It's just the body as a whole.
Wow.
That's just the tip of the iceberg.
I can tell. So welcome to the Mental Health Show with Robert Grigore. I am your host, Robert Grigore. For those of you who are new to the show is dedicated to breaking myths and lifting stigmas surrounding healthcare. And of course, particular focus is on mental health. Professionally speaking, I have over 10 years of experience as a therapist and have helped over 1,000 people, ranging from those literally living on the streets to those living and working in the tallest skyscrapers. I've also helped professional athletes at the highest level, such as NHL and MLB, as well as elite professionals in the entertainment industry. And on a personal level, I have experienced the high highs to the low lows. I survived bullying, low self-esteem, anxiety, depression, addiction, bankruptcy, suicidal ideation, domestic violence, and more. We live in an information age right now where the options are seemingly unlimited for healthcare knowledge and professionals. And as such, we hope that this show helps to bring clarity to the chaos and give you, our dear friend, the knowledge and the tools and the direction to make real, lasting changes in your life. At least know where to look to make that happen. This episode in particular is absolutely mind-boggling. You are going to see my mind blown on multiple occasions by what Dr. B shares here. I urge you to watch this and rewatch this and then share this and then reshare this with anyone that you think could benefit. All right, let's go. Today's guest is Dr. Sasha Blaskovich. Dr. B, if I may call you that.
Absolutely, yeah.
Okay. I'm very excited about this interview. So you're a board-certified chiropractic doctor specializing in head and neck injuries particularly, which means whiplash and concussions and maybe some other things.
Correct.
Yeah. You played football for over a decade.
Yep.
And then you personally experienced a post-concussion injury yourself when you played college ball. And then after that, you went on for 20 years for your clinical experience afterwards.
25 now.
25 now. Okay. Yeah, research is outdated. That's good. Okay. No, that's great. So you are the author of several books. Okay. One of them being this one here, Dr. B's Concussion Breakthrough, exploring the hidden connection to neck injuries and a simple guide to naturally heal your brain. This one here. This one in particular, I think, is a groundbreaking book because it helps to redefine some of the things that might be in conventional wisdom. Particularly, what I was able to find here is that maybe some of the concussion-like syndrome or symptoms that people experience may actually be neck injuries at the root versus, a brain injury particularly. So I'm sure we'll dive into that a little bit.
Mm-hmm. Yes.
What I also noted is that you're an author of two more books, Dr. B's Diagnosing, how do you say that?
Atlantoaxial instability.
Okay, that. Okay, and then this one, which is already dear to my heart. I haven't read it yet, but I'm going to now because I didn't know you. I just found this morning. I was like, oh my gosh, you have a book on healing the vagus nerve, which is something that, as what I work in polyvagal theory, it's all vagus nerve stuff. So I'm sure we'll get into that. So anyway, I'll put the link for these in the show notes. Okay, so you've helped over 1,000 people, 1,500 by now?
Probably a lot more.
Probably a lot more.
Yeah.
Okay, we're being modest. Okay, so over 1,000 patients, including pro athletes. I was able to find you've worked on some NHL hockey players, NFL, CFL, all the L's, I'm sure, right? And you're board certified not just in Canada, but he's certified in the US, the Netherlands, and you have 2 clinics, almost a third. We'll get to that one later, I'm sure. But so whiplash injury here, right, in Langley, BC.
Yep.
Whiplash and injury clinic, to be clear, and also the same name in Linden, Washington, right? Yes. We're going to do this in English, but you also speak Dutch and Croatian. Thank you for being here, Dr. B. I really appreciate it.
Thanks for having me and doing this.
It's my pleasure. I have a lot of questions, so I'm going to dive in if that's okay with you.
Sounds great.
All right. So you've been working with head and neck injuries for over 2 decades now, 2.5 decades, it seems like, right? Mm-hmm. What's something that most people don't understand about your field, but really should?
Well, as far as field is concerned, I think I've created this field that I'm living in, at least as far as my circle goes. It's a field that doesn't exist really as per a field that you can go and study for. It encompasses both the field of chiropractic, neurosurgery, neurology, physiology, and kinetics. And so ultimately, or biomechanics, ultimately what it boils down to is utilizing something from each one of those disciplines to try to get answers as to why the conventional reasoning that has been in place for decades, if not, a century at least, may have been missing sort of part of the boat. Wow. And that means that the brain has been a very widely studied organ, but yet there are so many unknowns in the realm of concussion that it's still an entity that gets stigmatized and gets criticized whenever somebody sustains a perceived concussion that, the rest and, be in a dark room and time itself. But when people come out of that and they go back to activity, whether it's just strenuous exercise or contact activity, and they get re-injured or re-flared up, And then they get into this realm of, post-concussive syndrome or chronic concussive syndromes. Not much is done in the sense of further evaluating like what else could be the ground cause of the symptoms that they're having. So it's just, we've already figured out that you have a concussion or a chronic post-concussive syndrome, and all the symptoms that you're exemplifying on a daily basis, we have remedies to subdue those symptoms, but not really figure out if there's a core tissue that we can address or core tissues that we can address. If we can see that they're damaged or see that they're somehow glitching, to be able to put you on a path of actual recovery as opposed to palliation, if you will.
Right.
So just keeping things at status quo. And so where that, in my world and in my own personal experience, ties back to is ligament injury in the upper neck. And so the upper neck protects and encompasses and houses the brainstem, or at least the lower part of the brainstem, where the vagus is one of the structures that branches branches off of that part of the brainstem.
Right.
And so when you have excessive movement and mechanical forces or mechanical motion that nudges up against that part of the brainstem repeatedly, but on a small micro scale, you have a repeated stimulation of those neurological structures, or a reduction in stimulation of certain neurological structures where you start getting glitching. So simple example is somebody who has this type of upper cervical ligament damage and resultant hypermobility of those spinal segments, which then nudge up against the brainstem, could at random times have double vision, blurry vision, tinnitus or ringing in their ears, temperature control issues where they feel like their head is flush, heart palpitations, digestive issues such as constipation and diarrhea. They could have acid reflux for no apparent reason, balance and coordination issues, memory issues, anger issues, multitasking issues, concentration issues. So all these things that are sort of concussive related as a sort of, let's throw these all in a garbage can and we'll call that concussion. These could all very easily be stemming from mild brainstem irritation due to vertebral segments that are shifting slightly more than they're supposed to after an injury that has actually stretched the ligaments that are supposed to hold those two segments tightly together with limited motion.
Wow.
Because the number one job for the spinal bones is to protect the lower part of the brainstem and the spinal cord, and for the skull is to protect the brain. So when those entities or those structures encounter too much movement after an injury, now the thing that's supposed to be protecting the neurology is the thing that's actually irritating the neurology. So you have all these potential symptoms of potential systems in the body that could be misfiring or malfunctioning at any given time, and not all at the same time. And I can get into what the reason for that is neurophysiologically, but which then poses a quandary for the physicians trying to deal with this, because they haven't been trained to look for the logical reason why someone would be having acid reflux, blurry vision, temperature control issues, heart palpitations, diarrhea and constipation, because they deem those all as separate systems, and they'll focus on the system. So there's something wrong with your stomach, let's give you acid blockers or hydrogen blockers. But yet they don't always have the acid reflux. So in my world, I'll always ask questions like, is that worse when you're in a certain position with your head and neck? And often enough, people will actually say, yeah, when I look up or whatever, I start to feel, either like POTS is a common diagnosis, postural orthostatic tachycardia syndrome.
Okay.
So when a person changes posture, so from lying to sitting or sitting to standing, their heart races.
Yes.
And so they get the label of POTS, and everybody thinks that the job is done, but that's just explaining what symptoms they have.
Right.
It's not even trying to figure out what's causing the stimulation of the nervous system to make the heart race when you change in position. Is it just a change in blood pressure, which is natural when you change position?
Right.
Because more blood has to be shunted when you're upright versus lying down. Or is it actually something stimulating the vagus nerve, telling it to inappropriately raise the blood pressure more than it should because when you change position, you also change the position of your head and neck. And that doesn't get really paid attention to.
Yeah.
It's just the body as a whole.
Wow.
That's just the tip of the iceberg.
I can tell. So what sort of seems to come through here is that typically doctors are going to be seeing or maybe treating the symptoms that aren't necessarily the real root cause. And so you have all people go around and they have all these different medications for different things and different treatments for different things, but it really could be the vagus nerve, it could be the neck. Particularly.
Yeah.
Wow.
No medication that I know of can alter mechanical forces being generated by moving components in the body.
Wow.
So when you have a mechanical reason for the stimulation of the nervous system, you can chemically mediate the response of what's happening, because that's a chemical reaction, but the chemical reaction internally of neurotransmitters can be stimulated by mechanical stimulation.
Wow.
So a bone slightly nudging up against the brainstem and lightly caressing it, which you would think is not a big deal, but because the central nervous system funnels information up and down and has responses for all body systems and coordinating all those things, if you randomly stimulate that, it'll misfire at the wrong moment. So there's no food present in the stomach, but yet you have stomach acid reflux.
Wow.
Which there's no logical reason for that unless some signal has been sent to the stomach.
Makes
So
sense.
the stomach itself rarely malfunctions, just does that randomly, because that involves a neurological stimulus to the stomach to tell the cells that do that job to release the acid.
Wow.
And that could, like I said, and often is caused by upper cervical issues, upper neck issues,
Amazing.
where there's the damage to the ligaments and the bone shifts a little bit, stimulates that portion of the vagus nerve, which then ties into the stomach, and you have acid reflux.
Yeah. And so maybe we can just give a quick description of the vagus nerve, because my explanation would be rudimentary, I'm sure. I know it's a nerve that's in the base of your skull that goes to basically every organ of your body.
Correct. Yeah. So simply said, the vagus nerve is the thing that we call it once it's actually exited the brainstem.
Okay.
And then it kind of bundles together in what would be considered like a PVC pipe in your house.
Okay.
So it's then a nerve that goes and traverses through your whole body and then branches off wherever it needs to whatever organ. But as it funnels back through that main PVC tube, once it reaches close to the brainstem, it actually branches out into rootlets. So different roots go into different parts of that part of the medulla, or the lower part of the brainstem. And, all those rootlets don't join at the same spot. So you would say, okay, the vagus nerve exits as one entity out of the brainstem.
Yeah.
And then it stays as one entity, and then it changes, branches off where it needs to. It also branches into the brainstem. So when it gets out of the brainstem, that's when it actually funnels into one structure,
Wow, like a splitter.
which we name the vagus nerve.
Amazing.
But if you trace it right into the brainstem, these rootlets might be responsible for stomach. These might be responsible for respiration. So, respiratory rate. This might be blood pressure and heart rate. This might be stomach acid. This might be balance and coordination. And so when you actually, depending on how high somebody's C1 or atlas bone is, and it's shifting in a particular way, it might be stimulating repeatedly the higher rootlets. Wow. And if somebody's atlas is slightly lower, it might be stimulating the lower rootlets. And at different times, it might vary from that depending on how severely they move their neck.
Wow.
Where it'll stimulate all of those rootlets. And then you have all this random misfiring. Wow. So that took me a long time, because if you try to Google, the origin of the vagus nerve, there's not a lot of stuff that you can find on anatomical drawings or whatever that really depicts that, because it's just labeled together, as a carte blanche vagus nerve.
Right.
And the assumption is that it's just this one thing that goes down and has responsibilities for different things. But as it originates in the brainstem, all those different things that it connects to have their own locations within the brainstem that then together, as they come out, funnel into one entity, which then eventually separates out when it reaches the area that it needs to. And that's very similar to the sciatic nerve. So you hear a lot of people talking about having sciatica.
Yeah.
And the assumption is that it's one nerve, but it's actually 6 nerves that come out of certain parts of the lower back and the pelvis, and they all connect together, and then we give it the name sciatic nerve. Okay. But then as it goes through the leg and butt, it branches off to different things, which is why people can have, numbness and tingling and weakness all over the place that doesn't follow the pattern of a herniated disc.
Wow.
And then you label it sciatica, but you have to then trace back which one of those segments or which area is it actually being glitched in. Wow. So that you can treat that area instead of treating it as a whole. And you generally get better results when you can trace back, just like with the vagus nerve.
Wow, that's fascinating. I'm going to encourage you to rewind that and listen to it a couple different times and go slow. I'm probably jumping ahead a little bit, but as a clinical counselor and the clients that we work with, one of the things we do is we teach our clients some breathing techniques and different types of things that might stimulate the vagus nerve. But what I'm really gathering here is, if that's not helping necessarily, really do the trick, then we're probably talking about something anatomically, that needs to be looked at. Wow. Okay. And I think this is a slightly different angle of this. So most people assume that an injury is something that could show up on an MRI or an X-ray, right? And if it doesn't show up there, it's not serious, right? So that's a myth, I think, out there. Or there's nothing wrong, exactly. How would you respond to that? And what should people understand about these types of invisible injuries?
That they are visible.
They're visible.
Well, first off, if I double back to your vagus component a second ago, there's absolute value, even if there is this mechanical component of the vagus nerve being repeatedly bombarded with mechanical pressure. Vagal tone reset is infinitely valuable for even patients like that or clients like that have these injuries. It's a great tool to have that allows you to repeatedly hit the reset button as opposed to being stuck in a spiral of the vagus nerve malfunctioning.
Wow.
Because even though it's got the mechanical irritation, you can still reset the tone by breathing exercises, meditation, mindfulness, cold water exposure, even not necessarily a plunge, but I mean, research shows that if you just put your face into a cold basin of water, it has a very similar effect to dipping your whole body in it.
Oh, thank God.
For the vagus.
Okay.
And so, but as far as doubling back now to the imaging component, I really don't think that there is such a thing as an invisible problem inside the body that we can't image. I think it's just a lack of understanding of what imaging to utilize for a particular diagnosis that you're trying to hone in on.
Right.
And that requires a very thorough understanding of the patient's history and what caused things to change where they're now stuck in this, paradigm of symptoms that they have. And so in my world, generally someone's had a slip and fall, a hockey injury, a football injury, a soccer injury, a skiing injury, a bar fight, whatever it would be. Yeah. And if you can sift out the details, so for me, it's important before I do imaging, and the number one imaging for determining whether there has been ligament damage is functional imaging. So in our case, motion x-ray. So it's real-time video movements of the patient, and we can see inside the movements of the bones with the video x-ray that we utilize. So that if the bones are moving too much, we know which ligaments should prevent that too much movement.
Right.
And when there is too much movement, with deductive reasoning, we can say those ligaments are damaged. Otherwise, that motion wouldn't be happening if those ligaments weren't damaged.
Right.
And then you can try to solidify that with a specialized MRI where you ask them to focus on those things. And even that's not perfect science, because these ligaments are usually, 1, 2, 3 millimeters thick. And MRIs are inevitably done with 3 to 5 or even more thickness of slices. Then that means that they'll take a slice of someone's body part. So say the neck, they'll skip 5 millimeters of anatomy, and then they'll take another slice. And then they'll skip 5 millimeters of anatomy, take another slice. And so if the pathology or the damage is in that 5 millimeter void, say you're dealing with a 2 millimeter thick ligament, and you've now done a 5 millimeter void of tissue.
Right.
And you can't really say, the radiologist can say, well, it appears to be unremarkable, there appears to be no damage to this whatever particular ligament. But they're just saying that because they didn't see a void. Wow. But that void could have been in that space that wasn't even imaged.
Wow.
Or wasn't even visualized by the imaging. And so there is always a way to image the proper tissue in a proper way if you understand what you're looking for.
Wow.
And so I don't think in neuromuscular and skeletal or skeletal anatomy that there is a way to miss something if you utilize the right technology to look for the thing that you think is damaged.
Wow. I didn't know that about how you could miss that 2 centimeter gap.
And that's
or
just one
imaging.
component. There's also the way they set the slicing angles.
Wow.
So if the slicing is going like this, but the tissue is in this plane, so they could be slicing through that and not actually see the totality of it. So
wow. Okay, so most people are going, like I had assumed, and I have somewhat of a background in like not a medical doctor, but most people I think assume that MRI is going to catch everything because it's the MRI and people wait 2 years to get in to see an MRI for an MRI scan. So incredibly invalidating for somebody to go in for an MRI and they're like, it's nothing major. Nothing there. So now they're going around thinking there's something wrong with me. I'm just, it's in my head, something like that. Versus, if they come to you and you know where to look, particularly, and then you actually can visually show on some sort of a scan that the injury is in fact, it's right there, I can see it. How validating that must be for people to go, I knew something was up with my neck or whatever.
And that was the same way for me. Whatever it was, 2006 was almost. Was that almost 25 years ago or 20 years ago?
That's a long time ago.
Right so that was my case as well. I'd had a bunch of different X-rays and things like that, and MRIs, and everything was normal according to what they're looking for and what they're doing, but yet I didn't feel very normal. And so, and the other thing with, for example, a neck MRI is that by design, they omit the upper part of the neck, which is the area that I'm talking about in sort of Dr. B's concussion breakthrough, that's the missing link in both severe neck injury and concussion-like symptoms, is the craniocervical junction where the skull meets the neck.
Wow.
And when they do a neck MRI, for example, when they do a brain MRI, it's perfect. They start at the base of the skull, they check the whole brain, wonderful. When they do a neck MRI, there's 3 potential views. There's a side-to-side view, there's a top-down view they can do, and then a front-to-back view. So the front-to-back view, they omit by default. They don't even bother doing that one. The side-to-side one, they do mid-skull to the upper part of the mid-back, so they catch the entire neck plus some here and some here.
Okay.
And then the top-down views, they start at the bottom of the second neck bone and pan down, so they omit the craniocervical junction because there are no discs in that region. The only thing that holds that region together are ligaments and muscles. So no discs. And inevitably, the majority of neurosurgery as it pertains to the neck deals with discs. So in order to not waste, time and scan time or whatever, they just omit the upper part of the neck because there are no discs there in the top-down view.
Wow.
And they start at the bottom of C2 because that's where the first disc is between C2 and C3. So they assess the discs, and if there's something surgical there, then the person gets shunted to a neurosurgeon for eval. But ultimately, again, in my world, that junction point there is crucial. And so whenever I refer people for an MRI, it has to be done in all 3 planes, and it has to include the craniocervical junction.
Wow.
And that's something that I would say 95 to almost 99% of medical doctors that send people for neck MRIs do not know. They do not know that part of the neck is omitted.
Wow.
And the ones that do know, they understand the reasoning for why it is omitted, and it's okay for them because they don't understand, at least not in much detail, the intricacies of the craniocervical junction and how integral it is in these problems that a lot of people actually present with that have nothing to do with the lower part of the neck.
Wow. That's fascinating. Okay. Thank you for sharing that. Digesting and thinking of, certain questions now to ask, when these eventually refer, obviously we wouldn't refer people for MRIs necessarily because we're not qualified, but
just understanding that if, something comes back as unremarkable or we didn't see anything,
it's not
that's not necessarily true.
Wow, that's amazing. I know that you said that you're saying that everything can show up and should show up in some sort of a scan. I'm curious though, from your perspective, since this is a mental health related show in many ways, how can emotions and mental health particularly play into the severity of an injury?
Yeah, so tying everything back to the vagus nerve, a person's state of mind, their outlook on life, their outlook on their injury. And part of that, unfortunately, has to do with the fact that they need to be informed of what their injury is. Otherwise, there's this fictitious thing. They know there's something wrong, and they assume that there's something wrong with their brain. And the brain scan was done, and they don't find anything wrong with their brain. So they must think it's some festering little microscopic thing that eventually is going to turn into a brain tumor or whatever else that's causing them to have the personality issues that they're having and the interpersonal relationship issues that they're having.
Okay.
But it actually is a physical and physiological problem that is irritating their vagus nerve, as I explained earlier. And then when that vagus nerve is constantly out of tone,
right,
it is completely glitching in the person's ability to coordinate thought, response, reaction to certain stimuli. Their glass is always literally full and doesn't take much for it to dribble over.
Right.
And so for them, and that was one big thing for me, was realizing with the problem that I had, that nobody was coming to my rescue. And I shouldn't expect anybody to understand what I'm going through, except for somebody else who's going through the same thing.
Right.
But the average person who doesn't live with this or doesn't live with a version of this, my expectation for them to understand what I was going through, as soon as I realized that I shouldn't expect them to empathize with me or feel sorry for me, or somehow, pat me on the back saying it's okay, you have this problem. Because at some point in time that becomes almost sarcastic like on their part. And so for me, the turning moment was when I realized, nobody's coming to my rescue. I shouldn't expect anybody to feel sorry for me. And I got to figure out a way to basically self-mitigate as much as possible and as frequently as possible, which then led me to, learning and listening to things that were, based off of, mindfulness and positive mental attitude. And, the glass is half full as opposed to half empty. What do I have gratitude for on a daily basis? And that actually has a
That's
dramatic
really
effect on the vagus nerve and the neurophysiology of the
Right.
brain itself, that our thoughts and our reactions to events and circumstances in our life predicate how severely the vagus nerve is being irritated by ourselves with our reactions. And so seeing that and realizing that changed dramatically things for me. And I try to, educate patients on that, is that the physiology and the interneuron connections inside the brain and the nervous system do actually mold. So there's this term, you've probably heard it, what fires together wires together.
Yep.
And so the more that a person thinks a positive thought, or so gratitude, their actual physiology, the actual connections inside their brain change for their better.
Amazing.
So they're going to benefit from that from a health and wellness standpoint by just thinking the opposite of what they might normally want to think. Instead of thinking, I'm going to be angry with this situation, I'm going to laugh it off and realize that, it's not the end of the world.
Yep.
And what have I got to be, what do I have gratitude for, as opposed to what do I feel entitled to that I'm not getting, or what am I bitter about that I didn't, encounter. So all the, anger, bitterness, lack, entitlement, and like what we feel like we should, like everybody should understand us. So dropping all of that stuff and just focusing on what am I thankful for? What's the positive in this situation? In this, where I didn't get what I wanted, is there not is there. So my mental state is, I didn't get what I want, but that means that it's not the right time for me to get that thing. So I'm going to keep moving forward, and that thing will eventually come to fruition. It'll eventually manifest. But right now I'm not ready for it. So like one of my favorite song lyrics is Garth Brooks's, one of God's greatest gifts is unanswered prayer. So when you think about that, the concept of that, people will be like, well, that's stupid. How does that make sense? But if you think about it, if you're not ready for it, you're not going to be able to enjoy it or somehow gain the maximum benefit out of something, versus when you are ready for it, it'll happen, and you'll be able to embody it that much more than at the moment where you think you want it.
I'm thinking about those that are tuning in. You said there's quite a few things that I just want to highlight. Our thoughts and our feelings don't happen somewhere out here. They actually happen in our physiology. You can actually feel them. Like you feel the anxiety in your chest, or the guilt in your stomach, or you feel all that physiologically. And what I love what you're saying is that when you think, particularly thoughts, whether they be positive or negative, they are changing your physiology. So whatever you have to do to think positively or to move in a positive direction, we have to do more of that. So it could be some breathing techniques, or meditations, or daily affirmations, or gratitude, or some other type of thing to help with your main thought process being somewhat positive. I also hear you saying not to be completely not in touch with reality, because if you have a severe neck injury, like we're not going to pretend like you can go skiing today, right? Like that's not true. But how can you look at this in a different way? So I guess maybe it's a question that somebody might ask themselves is, how could I possibly reframe this positively? You might not have an answer to it just yet, but how could I think a little bit differently about this?
The easiest way, for me, again, when I doubled back to my own scenario, back in 2006, when I had my motion x-ray, that was finally the moment where the stuff that I was feeling that I didn't have answers to, or everybody was telling me there was nothing there, was finally answered. And so I see that in patients that come through here as well, who maybe have only been dealing with it for 2 years after some kind of an injury, and some that have been dealing with it for 30 or 40 years after an injury, and have been sort of, yo-yoing through the medical system for the last 3 decades without any answers. And they have a stack of imaging that all shows unremarkable. And then they finally come here, and we figure out that all along their, concussive-like symptoms have been coming as a result of damage to the upper neck and the ligaments there, which will show up 30 or 40 years later, because anytime you permanently damage ligaments, they don't ever heal. There's no capacity for them to recoil back to their resting length and then patch up or scar up so that the stability of their spine is back again.
Wow.
It's not possible. The only thing that replaces the instability is degenerative arthritis. So as the little bone spurs grow together, the bones claw together and they stick together, and eventually you have, fusion, which is what eventually happens to an unstable joint, whether it's your knee or your shoulder or whatever it is. That's why they have, joint replacement surgeries, is because those things start to fuse after decades.
Right. Yep.
And the reason they start to fuse after decades and develop degenerative arthritis is because they damage ligaments 30, 40, 50 years prior to that. And that long-term use of a damaged joint that moves slightly too much or even more than slightly too much will just wear away the joint. So our joints are intended to have motion, but a limited amount of motion. And as soon as that it gets exceeded by 1 millimeter or 2 millimeters, and then is used for decades after that, it develops arthritis. So people come all the time saying, my mother or father had arthritis, so I got arthritis. I don't believe that there's not an iota of medical literature that proves that.
Okay.
But there's definitely always a history of injury to those people, and they generally do the same sports and do the same activities as their parents. So there's a logical reason as to why they may have injured the same joints or have the same kind of predicament.
Makes sense.
And like I said, ligament damage always ends up with arthritic change.
Wow. Okay. Huh.
But for me, mentally was knowing that there was a tangible abnormality, if you will, in my spine that was explained. And because I was already a chiropractor, I understood the physiology, understood the anatomy, I understood the pathology. So I was able to put it on its shelf. But that's why I spend a lot of extra time with patients trying to explain and re-explain this concept.
Right.
When we figure it out so that they can get a better understanding of it. And that's why I've posted as many sort of free things on my YouTube channel for them to continue to educate themselves and watch certain podcasts where I re-explain things in different ways where it's, maybe the one way I explain it in lay terms is not as conducive to them understanding as if the next time I explain it in lay terms to somebody else, and eventually it'll click. And when it does click, the patients really, really embrace it and can finally do something with it. So they finally understand the chronicity and the permanence of the injury, but also that there are definite tools that they can use on a daily and regular basis to hit the reset button so they live in a state of way better functioning than they did before that.
Oh my gosh.
And part of those things is sort of mindfulness and positive attitude and affirmations and not feeling entitled to certain things where you're not, getting your way or people aren't feeling sorry for you.
Yeah. Change your thoughts and how you feel, and you can change how you
personality
actually
and change
live.
your personal reality. Yeah.
Wow. And I was thinking about, these sayings that they're like, knowledge is power and clarity is kind. So you start to get like some more information here about what's actually going on for you and what you can actually do, and this is actually making a difference. I just think that's very, very powerful. There's another myth out there that we found that once somebody has a concussion, once they've quote unquote healed physically, the idea is that they should just bounce right back, back to normal. Here I am, but that's not often the case. What tends to linger beneath the surface even after the body is physically healed?
Ligament damage. It literally boils down to that. And so when you say that somebody had a concussion, again, the definition of the concussion in my previous life would have been similar to potentially yours. But my definition of a concussion, I don't believe concussions per se, as per the definition that I always lived with, and medically is still taught.
Yep.
I don't think that's a just definition. And so the assumption under concussion is always that it's just the brain.
Yes.
And when you say that, the mechanics of a concussion usually involve acceleration, deceleration, contact of the head or no contact of the head, it always involves the neck. The neck is always involved in that mechanism. And so whether you hit the head or don't hit the head, there's always an acceleration, deceleration in the upper neck as well.
Yes.
And so, yes, you get the, shifting around of the brain inside the skull, the coup contra coup that we all, the wonderful terms that we know about. And that technically can cause an injury to the brain tissue.
Mm-hmm.
But again, I delve to the imaging component of people that have been through that event and get imaging done, and there's never anything seen on their brain, even when they do with contrast, no contrast. It's rare that they actually see some kind of micro damage to the brain, which would tell me that either it's very, very micro damage, or potentially the damage wasn't actually done to the brain, and it was done to the ligaments of the upper neck, which then are supposed to protect the brain stem, which connects the brain to the body and the body to the brain, but yet can give symptoms inside the brain. And it's probably best that I get into that, because if you have damage to the ligaments in your upper neck, the two top bones don't stack properly on each other at any given time. So when they shift off of center, they will put some kind of compressive forces on the brainstem. And the center part of the brainstem has a drainage tube that drains the brain fluid through that tube down through the rest of the spinal canal. And so if you have this mild offset, that drainage tube gets slightly compressed at any given time. And so if you're making 10 cc's of CSF inside the brain, that means 10 cc's has to drain. But if only 9.5 cc's is draining because this has become slightly kinked, Now you're having 5.5 cc's accumulating inside your skull. And as you, with repeated cycles, 0.5 cc's, 0.5 cc's, 0.5 cc's, all of a sudden inside the skull, the actual caverns where the CSF is made start to distend, and it starts to seep out CSF throughout the brain on a mild basis, but enough to compress tissue, where the actual brain tissue now is going into a state of lower effective activity. So it's being slightly deprived of oxygen and nutrients, and it goes into a slightly lower metabolic state because of that mild compressive force. And then you start getting actual brain structures and tissues that are not exactly firing on all cylinders. And then when this gets, recalibrated, so for example, I address the muscles that hold these two things together because I know the ligaments have been injured. And when the muscles are reset through the technique that I use for treating patients, the muscles then calibrate holding this in alignment. If you will. It's not a matter of putting it in alignment and just it's going to stay there. Something has to hold it in alignment. So I address the muscles in the upper neck, whose job it is to hold this in alignment. And so when that happens, you now all of a sudden get a recalibration of the 10 cc's and 10 cc's of drainage, and things balance out. The person has less neurological symptoms and they feel better for a period of time. And it's all because of that upper neck. That's the only area that I'm addressing as far as therapeutically treating something. And because of the connection of the drainage through that region, and how that then, if it back pulls up into the skull, affects brain tissue as the fluid distends in there, and mildly compresses certain brain tissue, reduces its metabolic activity, thereby reducing its functionality, optimal functionality. You get those glitches. And when you recalibrate the brainstem region or the upper neck, the fluid dynamics recalibrate and the person has less brain symptoms.
Amazing. I'm thinking like a really overly simplistic example would be like a garden hose. If you just sort of, hold
the
sort of tight hair, right?
Garden hose, yes.
Oh, is that a thing?
It is, big time, yeah.
Okay. Well, that totally makes sense because you do that eventually you're just going to have too much going on, and like my kids play around in the backyard with the garden hose and just start spraying, out the sides and just messes with it. So once you can get it on straight. And work. So you could do some exercises then to strengthen the muscles around, because you can't really change the ligaments. You're saying, right? That's not really
the muscles
possible.
are inevitably not weak,
right?
They just become non-responsive. So the neuromuscular physiology of that is wherever there's a unstable joint, the muscle that spans that joint undergoes repeated stretch. And any muscle in our body that stretches beyond its normal acceptable stretch limit responds reflexly by contracting. So simple example, these two top bones, they go offset, which stretches a muscle. That muscle then responds by reflexly contracting and bringing things back into alignment. And as soon as it relaxes, things get offset again and it's got to respond again. So there's this tug of war that happens that is a single neural loop that goes from that muscle to the spinal cord and back to that muscle. But as that repeatedly cycles, there's a wonderful mechanism in our body that starts to send sensory information of that phenomenon to our brain. And the brain responds by sending a constant bombardment of motor impulses to that same muscle, forcing it to reduce its tone. So it actually gets tighter. It shortens up, which means that its tone increases. It becomes more toned or more firm. And why it does that is so that it doesn't undergo that stretch phenomenon, so it stays put on that spot. But oftentimes it actually does more than just stay on the spot. It'll actually calibrate things in the opposite direction because of that tone change. And so the treatment that I do is actually pressing on that muscle to get its tone to completely reset and release, so that system of stretch, contract can happen again, which is a good thing to have. But the muscle is strong enough to do that. It's when it hits that tone change that it's shortened so much that it actually doesn't have the capacity to stretch and respond, or to be contractile. So its ability to contract, it's like one of those ratchet down straps that you've done one cog too much, and you can't tighten it anymore and you can't loosen it. You got to fight with it. That's what happens to these muscles. And the wonderful thing is that if you just press and hold on that specific muscle, you can get it to release where it actually becomes functional. You can actually expedite the sort of reset process. And then it's able to coordinate that instability quite well for a short period of time, whether that's a day, 2 days, a week. It's very variable, dependent on things that you do or don't do throughout a day. But it absolutely can do that temporarily. And so my own personal case was wrapping my brain around, okay, I did this thing, which I figured out on myself, and it gave me dramatic relief and improvement of function, but it didn't last. So the sort of euphoric moment of, wow, that was amazing because I feel great. And then having
Oh,
that
back
taken
again.
away
Right.
was like, well, okay, did I do something wrong? Did I not
Crushing.
do enough? Well, what am I missing?
Yeah.
And when I understood the underlying problem of the ligament injury, and then the fact that ligaments don't heal, and the fact that this is a permanent problem, the constant, gets worse, and I can reset it, and gets worse, I can reset it. That became logical to me.
Okay.
So now it's become a way of life.
Okay.
And so it's still very effective.
Okay.
And barring a minor setback that I had about 5.5 years ago,
Okay.
things were on a trajectory of like really good, and the last 5.5 years have been worse than before that.
Okay.
Because of a re-injury,
Right.
and a very specific re-injury. And so, but for the most part, I can still help myself gain benefit from the treatment that I do on myself.
Wow. And the treatment that you can do on yourself, do you have a way of demonstrating that somehow?
I also have it on my YouTube channel, but it's ultimately I get into that muscle. I support my head so that I am not having to use my muscles to pull back.
Okay.
And I'll get on the specific muscle that in my case is the required one, and I'll press and hold for a minimum of 20 seconds. And I'm looking for a referral into my head, which is a trigger point referral.
Wow.
So these muscles all develop trigger points. And then after 20 seconds, I'll release, and I might find 1 or 2 more spots, and I'll switch sides and do the same thing on the other side.
Amazing.
And there's another muscle in the front that's really responsible for holding the head stable on the neck, which is this long muscle that we all have on both sides.
Okay.
So I'll treat those 2 muscles on both sides, and inevitably that'll reset me and make me feel way better.
Amazing.
95% of the time.
So quick question then. Since you have that on your YouTube, are you saying that it's okay for people to try
Absolutely,
that
yeah.
themselves? Okay, I
Yeah.
just want to make sure they
Yeah.
need to see you or somebody to
And
do that.
there are people from all over the world that have actually messaged me either through Instagram or through the YouTube saying
my
that it's
gosh.
dramatically helped them.
Nice.
And so, yeah, absolutely. The more people that can try that out, if they have these or assume or perceive that they have these problems but haven't been fully diagnosed,
Okay.
there's no harm in trying it.
Oh, I love that.
The worst thing
I
that'll
bet you
happen-
this can help too with that.
Well, that's why I designed that, was to be able to treat myself more robustly, if you will.
Right.
Because this can get tiresome,
Gets tiring on your
especially when
hands,
it's
yeah.
really bad and I got to press longer. Because I say 20 seconds minimum, but sometimes I find more benefit if I press for 1.5 minutes.
Okay.
And it's a lot better to do it with a device if you're going to do it that long.
I guess that really makes sense. Just sometimes when I have, and I don't know if I have a neck, maybe I have a neck injury. I'll have to find out now. But I think every now and then when I have maybe a migraine or something, if I just press under the base of my skull for a while, or I put my head on some sort of for a while, and I start to feel better.
People have very good
So-
instincts, but they're not really sure as to why those
Really know
instincts are
why
really
I'm
good.
doing that.
But yeah, that's ultimately it. So, if it gives you relief, then it's not a migraine, then it's a muscle tension
Muscle
headache.
tension.
Which,
Ah.
as far as the presentation, they're almost identical, because you can have flashes of light of the prodrome and
Right.
aura and all that stuff with muscle tension headaches as well.
Wow. Okay.
And again, the vagus nerve is the thing that dictates the diameter, so dilation and constriction of blood vessels. So you could have a migraine-like headache that is coming from an unstable upper cervical spine where the muscles are getting so tight, and the effect on the vagus nerve is taking place because of the shifted bones.
Amazing. Wow. Thank you for sharing that with me. Do I have to pay you now for that? No, thank
That's
you so
free.
much. Thank you. You deal with a lot of ICBC cases. So ICBC also has support for people that are injured, and they can receive care, mental health as well, but also physical health and everything. I think there's a myth I think out there as well where sometimes if people are in a minor enough injury, nothing, no, the car's not totaled kind of thing, and they can kind of get up and walk around, that they should be fine and just tough it out. It's just like no biggie, don't worry about it. What could be the dangers for that person to not get treatment early on?
I don't know if there's any danger for not getting any treatment early on, but if they did sustain a ligament injury in that scenario, like I said, the ligaments are going to be unstable if they did sustain that injury today, as they will be next week, as they will be next year. And so they could develop chronic symptoms. And the biomechanics of a situation like that, where there is no property damage or minimal property damage to the vehicle, is that any momentum forces, so forces, mass times acceleration, any change in transfer of energy, if it's not coming in the form of doing damage or crumpling metal components or plastic components of the vehicle, is getting transmitted to the occupants of the vehicle that's being hit.
Right.
And so you have this elastic component of an injury. So you could have a low velocity impact with zero property damage,
Yep.
but yet the person inside the vehicle has sustained severe injuries ligament injuries.
Ask my wife. I think I slammed on the brakes a few times,
Yeah.
and her neck goes a little bit
Yeah.
wonky. I bet you that's the same thing.
Yeah. And so this is not just a thought or a fictitious thing or something that is my opinion. There's piles and piles of research that have actually shown this phenomenon to happen, where you have a low velocity impact, no property damage or little property damage, but yet the occupants are severely injured.
Wow.
And so that's not a direct proportionality like the severity of the damage to the car. That's easy enough for, I think, a jury or somebody else to understand. Go, okay, that makes sense that you're severely injured. But when there's low property damage and still a major injury,
right,
that is absolutely justifiable, and not through a doctor's opinion, but through medical research that has been done showing that, and how the vectors of the mechanical force get transmitted from vehicle A to vehicle B in a delta V or a change in velocity scenario.
Wow. And so in the
how many G's can get generated in that type of an event.
So incredibly validating for those that are in a totaled type car accident, right? Maybe a little fender bender or something. That there's absolutely evidence to support the injury. And I'm going to ask, how should they verify with evidence that to the judge or to their claims coordinator? What would they need to do to dictate or show that there actually is an injury?
Get properly assessed, and use the proper imaging to determine whether or not they did. And moreover, if they have prior imaging prior to the event, that one can use to look at and compare to the subsequent imaging that was done, and even their doctor history. They were a simple example of a patient that I had. They were being treated for headaches. They saw an acupuncture doctor for that. The doctor had them fill out the patient forms, and they basically indicated that the headaches were like everywhere.
Okay.
They went and had that treatment, and then 2 or 3 years later they had a car accident where they were T-boned. So they were hit from the side.
Jeez.
And then they went and got treatment again, and the insurance company declined paying for their treatment because they pulled the old records and said, hey, you had headaches before and you're having headaches now, therefore this is a previous injury or previous problem. But if you look at the actual diagram that the patient filled out, which nobody looked at until I was asked to basically opine on the actual situation, if you look at the diagram from the acupuncturist and the diagram from, I believe it was a chiropractor, this patient came from Edmonton.
Okay.
If you look at the then clinical notes of the chiropractor that they saw, it was very distinct that the acupuncturist 3 years prior to this collision, it was everywhere. And in the situation where they had the T-bone, say they were T-bone from the passenger side, all of their migraines or headaches were on the left side. They weren't distributed everywhere like they were with the acupuncturist. So yes, they had headaches then. Yes, they have headaches now, but they're not the same headaches. And then when we did the imaging on this patient, the mechanics of being T-boned from the passenger side would push their car that way and make their body go the opposite way. So everything over here was stretched and everything here wasn't.
Right.
And so when we did the motion x-ray, and then with their mouth open and their head tilting to the right, head tilting to the left, when they tilted to the right, their C1 had an overhang, which is damage to ligaments.
Okay.
And when they went the other way, there was no overhang. So the cause and effect of that T-bone trauma and the imaging that we did subsequent to that proved cause and effect. So unless there was some other, event that somebody could find in their doctor's clinical notes where they were impacted from the right side that could explain the findings on the motion x-ray, I would have to take the opinion that that event was the thing that caused what I was seeing on the motion x-ray, and that the headaches that they were having were completely a different origin and a different pathway than what they may have had at the acupuncturist 3 years prior.
Wow.
And so in providing my opinion on that and the evidence backing that, this patient's care was then covered by the insurance company because we weren't dealing with the same thing anymore. So there's always a way to, do crime scene investigation or forensic analysis that then does justice to their current situation versus just simply going headaches then, headaches now, must be the same thing.
I just feel all the people that just got filled with some hope here, for the type of injuries like that. Oh, thank you for that. Okay, so I want to talk a little bit about some of the other types of support. So I know that obviously you're talking quite a bit about, head and neck injury support, particularly the C1 and C2 and the vagus nerve. I'm curious about, as you worked with patients sort of longer term with their care, what types of other supports can be useful for patients to have?
The common ones are physiotherapy, massage, acupuncture, naturopathy, and tying into your line of work. I
Okay.
think it's very beneficial. I have had a lot of patients that get to the point of desperation as far as the anxiety that they have and the sort of lack of the system in any way recognizing what's wrong with them. And so clinical counseling,
Right.
because it starts to affect their family life, it starts to affect their personal life, work life, everything that they
Yeah.
might have going on
Right.
gets affected by the fact that there's this lack of understanding or lack of realization that they actually are dealing with something. And so bouncing that off of a clinical counselor, I found has been dramatically effective and beneficial to the patients. And before we even started, I was telling you about a patient of mine that is a clinical counselor, and so he went through the whole ICBC thing, and there are, and thankfully now we've met, so now I can chime in on you as well. But there have been patients that I have referred to him who absolutely require that kind of care, and they've all dramatically benefited from that.
Lovely.
So I think there's a massive value in counseling people through these long drawn out processes, such as automobile injury claims, where it's not resolved within the usual 6 weeks that the insurance company believes everyone should be healed in.
Right.
And so when they're not, then eventually they get into a predicament where they need some assistance with their mental fortitude.
Right.
And I think that's very relevant of your profession as to what you can bring to the table for those types of patients. Absolutely.
I appreciate that. I think probably within, if somebody does have a family, and I'm sure part of the conversation, of course, is the car accident or the injury, and it happens. But I think over time, friends and family start to get a little bit, overwhelmed with it.
You should be over this by now.
Yeah, exactly that. Like, come on,
Put
let's
milk
go.
in it. Yeah.
Okay, so those are the things that people are hearing, and so then it does make sense. And of course, they're doing all of the things that the insurance company is telling them to do, right? Is the physio, massage, chiropractor, all that stuff, and then I think that appreciate that, because we do get a significant amount of ICBC clients or people that have had some physical injury, and as you mentioned at the very beginning, what you think about and how you feel absolutely affects your physiology. And so at least I found it, and I haven't done any imaging with people on this, but I've noticed when they're highly distressed emotionally, their physical symptoms are twice as bad, 10 times as bad, depending. And then when I can bring that down, or when we can bring that down, maybe their pain isn't all the way gone, it's still there, present, but it's manageable now. I can handle this, or I can adapt to this, or something kind of. I really appreciate that. Thank you.
Yeah, this whole system takes you out of the fight and flight for a period of time.
Yeah.
And gets you into sort of a healing mind frame or healing state of mind, physiologically and mentally. Otherwise, you deviate back towards the fight or flight, which is just survival mode, basically, which is what everything in society and life brings us to. And so it's invaluable as to what you do, helping people get out of fight and flight, and teaching them how to sort of repeatedly get out of fight and flight, because they're going to delve back into it.
Yeah.
Even at the best of times.
There's something called the polyvagal theory, which I'm very into, and there's sort of different levels of the nervous system response. You got the ventral vagal, calm, grounded, green. It's in the green zone, or the calm. It's all about connection and grounded and peaceful, and that's where we want to be. Then you got the fight or flight, and that's sort of next level up. That's sort of hyperarousal, and then you got the dorsal vagal shutdown collapse response at the very top. If it's overwhelmed, depression, it happens up there, addiction, suicidal ideation, and so when you're at the very bottom, where we want to get people, once they're doing all of the physical things they could possibly do, eventually, I think tapping back into that social component is so helpful, because I think being part of a group or some sort of social connection is a healing piece just in itself. Just having somebody else that's unbiased that you can talk to about this, versus a family member who's had enough of it. And they might mean well, and they love, of course, the person, but it's hard if you've never been through it. You don't know what to say, and you're not a counselor yourself, or a chiropractor yourself. What are you supposed to do? So
absolutely. And I think the biggest thing that people get into at that point in time is, if they don't get referred or somehow have the benefit of being in the hands of someone like yourself, is that they'll start getting medicated. So SSRIs, so antidepressants and other sort of medications that are intended to subdue the nervous system into submission, I think have an adverse effect, both physiologically, mechanically, and mentally.
Right.
That isn't technically the best solution for that individual. So I think before someone gets that far, they should generally be referred to someone like you before starting any antidepressant kind of therapies. It's my personal opinion.
That's so. I mean, from our perspective, I always think about, medication is not that I'm not anti-medication whatsoever. It's useful and it'll get you over a hump of something, and I'm not a psychiatrist, so. But I do think that if we're numbing the negative, we're also numbing the positive, and it just sort of has an adverse response.
Because ultimately, the scenario there is just do that and hope it all goes away at some point in time. But the reality of the matter is, as far as my 25-year clinical career, is that it's rare, if I've ever seen it once at all, that somebody's problems just go away eventually, and the medication was just a great way to get them through that. I would err to say that most people still continue to have these issues decades later, and was the medication necessary? Maybe, like you said, to get them through some major hump, but ultimately not for their overall well-being 20, 30 years later. I think it's detrimental to their health.
Like we talked about, that pain that lasts for a long time. There's a difference between acute pain and chronic pain, and from my understanding, acute pain is 2 to 3 months maybe of like an injury, a broken bone or something like that. It just takes about that time to heal, and after that we're going into chronic pain. Subacute and then chronic. Okay, thank you. And I think over time, pain and dealing with these injuries can affect people's sense of self, where they become like, pain is part of who I am. This is just I am the guy that's hurting, or I can't do this anymore. This becomes who they are. How can you help people to rebuild their confidence in themselves, like through their body?
This is an interesting question, because when they're in the heat of the process of being involved, for example, in a personal injury scenario, like an ICBC type scenario,
right?
Everybody that goes see for help is always focused on their problems, that patient's problems, and so it continually reiterates that they are dealing with a problem. So none of the focus with any of those therapeutic individuals is moving to the next step, which would be actual healing. It's always about, tell me where it hurts, tell me what's bad, not tell me what's good and what's positive in your life, but what's bad. And so the documentation requires all the badness, and them relaying their last week of life experiences all about the bad things that happened to them, and nothing about the good things. So I think when a person's not in that scenario where they're having to repeatedly emphasize and focus on the bad, is when they can finally focus on the actual good of life. And so everything, I think, that ties into dealing with a person who's been injured, especially if there's some kind of a claim that's open, is keeping them in a state of victimhood. And getting themselves out of victimhood requires them realizing that they're in victimhood. And so and once you realize that, you can put everything on its proper shelf, whereby you live your life not as a victim, but as somebody who's beating some kind of a problem, as opposed to somebody who's always dealing with some kind of a problem.
Right.
And I actually did a podcast about 3 years ago with a guy named Dr. David Martin, and it's on my YouTube channel. And we literally talked about this whole notion of victimhood, and how important it is to get in the right state of mind where you don't see yourself as a victim, but as a survivor, I guess. I'm not sure if that's the right term for it, but as somebody who's actually beating something, as opposed to somebody who's being beat down by something.
Amazing.
And so it's, again, ties back to a state of mind, right? So you can see yourself as, in a bad predicament, or you can see yourself as working through overcoming a predicament to become stronger, right? So you're gaining, you're learning, you're growing. Without these adversities, there's no way that you could become a better person. So wrapping your brain around this whole negative thing that you're going through has a positive future outcome, that you're going to be stronger, better, more equipped. And a lot of people that come through here will say, I'm going to write a book, or I'm going to do something so I can give back and help people on the back end of this.
Right.
And so at the end of this whole so-called negative experience, you can do something positive with it.
Right.
And so I think changing a person's mental state of mind, and the best person to do that is themselves, where they get themselves out of being a victim again, feeling entitled and feeling like everybody should be feeling sorry for them. Like it's just, it's a switch. It has to happen internally, and it's guidance of someone like you to help them realize that. And I try my best to also help people realize that they're going through tough times, and all the stuff that they're having to go through is to be able to fill all the voids, or all the, check off all the check boxes for an insurance company. But at the end of the day, when that's all said and done, their whole focus has to be on how this has benefited them. And it does. It's just that they don't generally realize that as they're going through it.
Right.
But down the road, they have become a more resilient and more understanding and a more empathetic person themselves as a result of this, whereby they can then give back and help someone else get through it. So, I think you were talking about this either earlier during this, having, this sort of Alcoholics Anonymous support group, where people that, get together and basically help each other get through the scenario is extremely effective in understanding that they're not the only ones going through this, because they feel like they are.
Well, pain is so isolating, right? Like you're the only person that's feeling your pain, so you like it.
But just the whole family problems too.
Correct.
Like arguing with their husband, arguing with their wife, yelling at their kids. And they think they're the only one that's falling apart like that. So when we get into a group scenario where they're like, "Oh, I'm doing that too. You are really? Oh, wow, no way."
Yes, maybe family therapy or couples counseling or something might be helpful to help people deal with, somebody who has an injury. I really love what, one of the philosophies that we use in our clinic is to focus, as you said, not just on the symptoms or the negative or what's not going well. Of course, we're going to validate that. We're going to work with that. Those are the issues. But we really focus on building the adaptive neurological network, so that, instead of if the pain has somebody, or, thinking that they're broken or they're not good enough, or they're somehow there's something wrong with them. And that was a little bit, there is something wrong with you to some degree, or you have a ligament that's never going to grow back the way it is. So rather than trying to believe, like I'm normal and I'm fine and everything's okay now, that's not realistic. But it might be, how can I adapt to this? How can what I heard you say really clearly was that post-traumatic growth piece, right? How can this actually be maybe the best thing that's ever happened to me? That's very difficult, pill to swallow for somebody that's dealing with it. Like if they have a knife in their leg, I use this analogy all the time. Like all you can think about is the knife in my leg that really hurts. It's hard to think about how maybe not walking for 6 months was actually beneficial for me. So I think that's something that'll take a lot of work. But I love that, framing it that way for people to really think about, how is this benefiting me right now? And I know the gratitude might be tough at the moment, for somebody to go, dive right into, but how can I sort of work my way up to gratitude particularly?
Absolutely.
Wow, it's amazing.
So the definition of two words makes all the difference in this paradigm. And that is that the patients themselves, the insurers, their doctors generally, they're all discussing the term disability.
Right.
And so disability means you actually can't do something. You're missing a limb, so you can't pick your nose with your right hand. So the difference between that and what we're dealing with in general, which is impairment.
Yes.
So they have an impairment and not a disability. That. So it's not that they're not able to do stuff. It's that they're able to do the stuff, but they either have ramifications, so they're flared up and they're set back for a few days or a week or whatever after they've done that, but they can do it. So it's not that they're disabled and they can't do stuff.
Wow.
They can do everything. It's just that they pay the price afterwards.
Amazing.
And we know why they pay the price, because we figured out what their injuries are. And so making that distinction for an insurance company and or another doctor who's talking about, well, this patient, whatever they say, they use the term, they always, the reference in the back of their minds and what they're talking about is always disability.
Yes.
And not impairment.
Yes.
And so for example, when I write my report for the motion x-ray, it's always, the findings are always correlated to the American Medical Association's impairment ratings. The AMA has guidelines for impairment ratings. Wow. So they're not disability ratings, they're impairment ratings. So a person that has particular ligament damage in their neck or somewhere else, based off of the AMA guidelines, will be distinguished as being whole person impaired.
Wow.
Which means they might have a ligament injury in their neck, but it affects their whole person.
Wow.
So their whole person impairment might be 25%. So they're 25%, or they're 75% the person they should be when they do that activity because of the damaged ligaments in their neck.
Wow.
So it's not that they're disabled and they can't do it, but they're gonna experience an impairment as a result of having done that activity because of the damage that's been incurred to their ligaments. And so when that should literally become household conversation in the medical community, is impairment versus disability. Yet everything is focused on disability. You get paid out for disability, you get a disability,
You're right.
long-term disability, short-term disability, whereas impairment is not even a term that is entering these conversations.
Wow.
Because these people aren't disabled, they're impaired. And so focusing on their impairment and recognizing that it is an impairment and not a disability, and that somehow they can get compensated for the impairment that they're experiencing. So the lower quality of life, the decreased ability to do something. So they have this thing, decreased future earning capacity. Yes, absolutely.
Yep.
And it's not because they're missing an arm and they won't be able to, churn the butter with their right arm. They'll have to use their left arm and they'll get overworked. It's because they can do that. It's just that after they've done that, they're going to be much more fatigued and much more set back than their counterpart who is not impaired and doesn't have these injuries.
I love that.
But
that's literally happened in 2 of my sessions over the last 2 days. There was two chronic injury clients of mine who were talking about, and they used the words, I should know better. I can't walk up the hill. I should know better. I walked too long, I walked 20,000 steps instead of 10,000. And I stopped them. I just intuitively did this. So obviously I was on the right path.
You walked up the hill, but
you can actually do. I just noticed that you actually can do that. It's just that the recovery time is longer.
Yes.
And so I'm gonna make sure that all of our clients use the words, hopefully all of our clients, but all of our therapists use the words impairment versus disability.
Yeah, huge distinction difference.
Thank you for that.
Yeah, huge distinction difference.
Okay, that's going to be a soundbite for sure. Thank you. I saw it in your eyes earlier that you really care about these people that you work with. You're trying to change lives, and I love that it's not just a neck that you're fixing. Like, you're working on the whole person. You're working on their belief system. You're working on how they live their life, and that this can be some sort of a benefit. I mean, look at your career, right? Like, would you have gone down this pathway had the injury not happened to you? I'm gonna guess not. Right? You may have still been a chiropractor, but maybe not. With this focus, right? Is there anything else you want to say about your own personal injury experience that you think maybe people might want to know about? You don't have to get too personal, but
I think I touched on it earlier. My biggest turning point from a sort of family dynamics standpoint was where I realized that I shouldn't expect anybody to understand how I feel. My wife included, my parents at the time, anybody else that's in my circle. I shouldn't expect them, if they do empathize and repeatedly for a long period of time, great.
Amazing. Yeah.
But I shouldn't expect them to do that. And so when I dropped that expectation, it made things much more digestible, because the reality of the matter is that they don't perpetually understand and empathize. But as long as you don't expect them to, it's a much better dynamic as far as the give and take of that. Right. And so I've had multiple patients where the husband or the wife had the injury, and they would relay to me that they're having problems at home because of the fact that you get to a point where the other person's like, you should suck it up now. It should be this is enough. I'm done sort of supporting you and empathizing with this. And when I told them, I guess they were probably expecting me to give them some magical answer as to how to get that person to empathize. But the slap in the face was, I said, things are going to change for you once you stop having that expectation, and don't demand of them to understand how you're going through. Don't demand of them to empathize. Don't get angry with them for not understanding you. Do the opposite of that. Don't expect it, and don't be angry when they're like that. And several of those have come back and said, you saved my marriage, because I no longer, and it changed the dynamic of the other side as well, right? So this patient changed their personality, and what they were expecting, what they were thinking they were entitled to, and they no longer had that. So their actual personality changed. And so the other side experiences that, and so the whole personal reality of this ring of events changes as well. It's like they've manifested a change just by changing, because you can't change anybody else.
Right.
You can only change yourself and how you respond to circumstances. That will make a change in the totality of that encounter. So the only thing that you can change is yourself and how you respond to adversity or whatever else. It's not the adversity itself, and other people is influence in that whole totality. It's yourself. So I've always said, for me in the past, my biggest obstacle to anything beneficial happening was me. I was my biggest obstacle. And I think if most people sort of would step back and and get the chip off their shoulders, and not that it's a chip that they intended to have, it just happens.
Yeah.
If they were to just step back and go, I need to change and not everything around me needs to change. I have nobody to blame.
Yeah.
I just need to be the one that changes. Then everything around them changes for the most part to their benefit.
Oh, thank you. That's very wise. Thank you for that.
Yeah, I was my biggest obstacle. And so as soon as I realized that, things got better.
So true or myth? Only athletes get concussions.
Myth.
If your imaging is normal, you're fine.
Myth.
Whiplash symptoms always resolve quickly.
Myth.
You can't recover without surgery or drugs.
Myth.
All right. Well, thank you so much, Dr. B. I really
pleasure.
appreciate you being here. Obviously, we'll put your directions to your website, and in the show notes, and your YouTube channel, which I didn't know you had. So I'll put that in there.
Everything
sure
on
too.
there is either in some way related to this atlantoaxial instability, as far as educational. If it's not for comic relief, I just love it when you watch reels on Instagram or wherever else where people are just doing stupid things and smashing their heads and whatever else. So that's just for comic relief.
Okay.
And we have a segment in there, what brings you in today? So me basically throwing a folder on the desk going, so what brings you in today? And then it pans into a reel of people like just bashing their heads in.
Okay.
Doing like skateboarding or whatever else. So but that stuff fascinates me.
Fantastic. Anything else you want to say to the audience before we wrap up here?
No, I just hope it was useful and that if it benefits one person, we've done justice to this today.
Absolutely. And I've learned a lot already from you on this interview. And I'm going to encourage you watching to rewind, or if you're listening, listen to a few different times, because Dr. B shared so many pieces of information, and I can only imagine, Googling some of these things to look it up will be really helpful. And so obviously I'm going to encourage, if you have any questions about anything that you've heard here, any comments, put it down in the comment section, and I'll forward them off to Dr. B, and maybe we'll get a couple answers here. I know you're really, really busy, so we won't expect a lot, but thank you for that very much for being here, and appreciate it.
Appreciate it. Yes,
thanks
you
so much. Grigore Counseling and Associates is a Canada-wide evidence-based mental health clinic offering CBT, DBT, EMDR for individuals of all ages, as well as couples and families. Our therapists collectively have over 50 years of experience, and we are proud to welcome clients of all nationalities, all ethnicities, all cultures, all sexual orientations, neurodiversity spectrums, and more. We have BIPOC therapists offering services in Hindi, Farsi, Mandarin, Cantonese, in addition to English. We offer affordable rates, evening and weekend appointments, and we're accepted by all major third-party insurance providers. So if you or someone you care about could use some support, we encourage you to reach out for a free 20-minute consultation, totally free, to see how we can help you. A better future really is just a few clicks away. It's that simple. We thank you for watching this episode and look forward to seeing you on the next one. And if nobody has thanked you for being alive today, let me be the one to say it. Our world is better with you in it.